Good evening. My name is Dr. Divya Parashar, and I am a rehabilitation psychologist. Till May of 2019, I was heading the Department of Rehabilitation Psychology at the Indian Spinal Injury Center, after which I went into my own private practice. Um, the topic that I was invited to speak on today was about the nuts and bolts of disclosing the prognosis after a spinal cord injury to our patients and their families. Um, and so if I look at the relevance of the topic, we all know that spinal cord injury is a traumatic and unexpected loss, which adversely affects our patients' lives, not just physically, but emotionally, socially, vocationally, and in every aspect of their lives, especially if it's a complete injury. Prognosticating outcome is definitely of great importance in order to plan realistically what they're going to do in rehab and post-discharge, how their life is going to be led and how they need to reintegrate back into the community. And of course, in my experience of working for about 20 years in this field, communicating the bad news is not an easy task, and it often creates distress in the clinician. And if you look at it, then of course, when at least in my conversations with the spine physicians and surgeons, the communication aspect of prognosis isn't something that is taught in medical schools. So of course, when you're talking about bad news and you see patients react to that news, of course, it does create distress, which often leads to no set ways in which that communication exists. So, of course, I mean, there has been a plenty debate about whether or not to tell, when to tell, and of course, the different perspectives I've heard is if we tell soon, patients may get depressed and anxious, which compromises rehab compliance. Some say that patients will figure out themselves as time passes, so we can leave it vague. They'll of course know as the days and months roll by. There are different perspectives clinicians may have, and then we all say, okay, that one size does not fit all. But of course, when we talk about breaking that news or discussing that with our patients, what my experience has shown that, of course, the perceived adequacy of the information, how much we tell them, and the way in which it is told, and the way in which the clinician resolves their concerns, has a discussion, of course, does lead to a better outcome than just breaking the news abruptly, which the person may not be ready to take. Why is it important to discuss the prognosis? And by that, I mean to discuss the permanence of the injury so that people can plan their lives ahead. And of course, I will say that when you are discussing a prognosis of seeming permanence, and especially in a country like India, for instance, where the infrastructure is so poor to support our patients with spinal cord injury once they get back home, it is bound to cause some emotional distress. It is bound to create a shock or a denial or anxiety or a strong emotional reaction to that news in any case. But the failure to discuss prognosis, to not tell the truth, of course, interferes with their coping and their subjective well-being. It does create uncertainty and confusion. And it may pose, the biggest one that I have found is that it poses a resistance to rehab and reintegration. So when somebody is participating in rehab, they're doing their wheelchair transfers, they're learning bladder and bowel training, but they still say, I'm going to walk one day. We may, kind of be empathetic and sensitive towards that and not counter someone. But when somebody with paraplegia, for instance, refuses to learn wheelchair transfers or refuses to learn intermittent catheterization, that becomes very important to discuss the prognosis so that they know that these skills training is very important for them to lead that life going on. So of course, all this sets the stage for the patient's biopsychosocial rehab as an ongoing process and not just after the surgical management in that way. There is definitely no ideal way of breaking the news, but of course we can customize our approach based on a patient's age and education, their background and career, the importance of body image, what their body meant to them before the injury. So for instance, somebody who's been a bodybuilder or a sports person, they may have a bigger impact, in that sense. Gender, of course, plays a situation, it plays a role, life situation and their emotional state. So we must take into account all of these factors before we break the news in that sense. I like this ABCDE model that came about. Breaking the news isn't just a simple transmission of information saying, you have Asia level, A injury, and it's at this level. There needs to be a process which if we follow, of course, has a huge role in making the patient be comfortable and gives them the time to absorb the information and also to ask questions. The ABCD model, which I'll talk about, is again the preparation for discussing the information, breaking the news, building the right environment, and that of course is also something important, which we'll discuss in the next few slides, how we communicate, how we deal with the patient and the family's reactions. And like I said, of course, there will be distress, but how do we sensitively deal with them become important. And of course, encouraging and validating and saying, yes, we understand that this is a difficult time for you, but we are there to support you in whichever way. That encouragement, empathy, and validation is very important as well. In my practice, there've been often discussion that who breaks it. So sometimes a physiotherapist will say, "Oh, it's a psychologist," and it used to fall on me. And as a psychologist, I strongly, strongly believe that the responsibility lies with the senior, most experienced physician involved in the case. So if it's a spine surgeon who's operated on the patient, it is very crucial that they be the ones to discuss the prognosis with the patient. It should not be delegated to residents or medical students unless, again, they have worked with extensively with that patient. So a physiatrist or a case manager may also be somebody who may relay that information. I will strongly, strongly encourage that there needs to be an investment and commitment of time that sets the stage for a therapeutic relationship. And it's not just the information, it's not just the knowledge of the injury, but it's the sensitivity, the way in which that information is relayed, and the availability and the willingness to answer difficult questions that follow. A lot of times I've had the prognosis being asked from the patient to me or to a physiotherapist and occupational therapist, because they are the ones who the patient is interacting with on a regular basis. So if somebody asks any of these people of the treatment team, any member of the treatment team, I have often sensitively redirected that to the physician, and I will alert the physician saying the patient is asking the prognosis, so we need to deal with that also. Where, and that's important, not bedside, not in a shared ward, not where there are many people present, but in a private and quiet setting. So if the physician has an office, I would often say invite the patient there. And ideally spend time with the patient first, because sometimes the patient may not be comfortable with sharing concerns in front of family. But again, sometimes the patient may prefer family be present, but it's always a good idea to ask the patient, would they like to speak alone or would they like the family or friend to be present? Sometimes it's important to have any other member of the team present for support and supplementary information. So it could be a nurse, it could be anybody who's there, who the person can go to later, because we understand that the physicians have busy schedules. That person be available to clarify for clarifications, for answering questions which may have arisen out of the discussion. It's very important that once the prognosis has been discussed, if you have a psychologist or a peer mentor or a peer counselor on the team, that they should follow up with them to learn what the person has comprehended, what their emotional response has been, the impact that discussion had on the patient, um, and the news had on their motivation for rehab. We may see things where people may continue with rehab as was going, or they may resist it, saying, what's the point of going through the rehab when I'm not going to be able to walk? So again, having a discussion, or they may be maybe just assimilating the information, it helps to follow up with them to see what meaning they took away from that discussion. How? And there's a reason why I will keep saying sensitivity, sensitivity, sensitivity. Again, I will re-emphasize that important aspects need to be taken into account. The person's personality, are they generally somebody who are emotionally reactive? Do they have good coping skills to begin with? How did they respond to stress earlier? The culture in which they are socialized in, age. Again, please looking at predisposing stressors and mental health problems, especially if somebody had sustained a spinal cord injury because of a suicide attempt, or have had a mental health history in the past. Those are very important aspects to take into account before breaking the news. Abruptly breaking the news leaves a negative impact. So if somebody on rounds asks a doctor, will I ever be able to walk? And the doctor says, no, you will not be able to, and then walks away and goes on with rounds again, that leaves a pretty negative impact on the patient. So again, setting that therapeutic environment and that stage becomes important in that way. How is it told? So, of course, the minute the patient sustains the injury and they're in the hospital, they themselves are beginning to notice changes in their body. They are noticing the lack of mobility or the sensation, or the fact that they are not able to control their bladder or bowel, or that they are unable to even notice any sexual functioning happening. So they themselves are fearing the consequences. And so the key questions one does need to know about, and they're going to talk amongst each other. Patients tend to talk between other family members or other patients. What does the patient believe or has been told about the injury? And these are the questions I ask them, that what are some questions that exist in your mind about the injury? So whenever somebody asks me about prognosis, I'm not going to dismiss it and say, go talk to your doctor, but I will ask, what have you been told? What do you believe? So that I can also communicate it to the physician, saying this is what the patient believes or has been told. And these are some questions that exist. So could you sensitively answer that? Again, I know we are pressed for time, but this is such an important topic that it should not be rushed. It should be gentle, unhurried, and uninterrupted. So, and this sets the stage for their rehab and how they approach their life in the long term. So, again, please take care of phone calls, people. Just make sure that it is that whatever time you delegate to that patient, it is just their own time with them. Physicians should be prepared with all the relevant information. So the type of fracture that has been sustained to the spine, what the surgery has been, what is its role. A lot of people think that when you're operated, that means you're fixed and you'll start walking again. Any other medical complications, what are the latest scans that reveal, and what's their current medical and functional status when it comes to physiotherapy and occupational therapy? How much, what have they been, what abilities, what are they able to do functionally, so that again, we have some hopeful information to provide to them as well. Um, What you say is as important as how you say it. So, non-verbal behavior. Please don't stand on their bedside and look down upon them. These again make very important impact on patients. It's always helpful to sit at their eye level, look directly at their patient, sometimes leaning in just to show that you're supporting them also helps, and that you're listening, using eye contact, using body language. So if in your culture, it's okay to just kind of put a hand on the shoulder, again, what's culturally relevant, whatever body language you can use to convey warmth, to convey empathy, to sit in silence so that they're processing what's being told to them, to look at them with encouragement and reassurance. Please allow pauses and time for patients to collect his or her thoughts, to formulate questions. Making you being there just in silence while they may think of something to ask also means a lot, which shows immense support. And you can always say, if you don't have any questions now, I'm available to talk to you whenever I see you next. So just make sure that you're providing that support to them. Speaking slowly, clearly in non-medical language, in language that they are able to understand. Um, Providing information in small doses. So if you're seeing that they're becoming emotionally very reactive, or that they have a glazed look and they're unable to just process what's being said, it's important to kind of keep a check on that, and maybe have a ask if they want to have the continue with the meeting, or set a time for meeting later. But again, check, are you with me? Any questions? Would you like any clarifications, etc.? And using the patient's language of choice or interpreter. If the language that is spoken is not the same as what the physician's language is, please use an official translator or an interpreter rather than a family member, because again, the meaning may be lost if somebody who's very close to the patient is translating that information, and we won't get to know what's being told to them. Be honest but not blunt, again using the time, so makes patients angry and leads to distancing if it's suddenly broken up. But again, being honest is often about the neurological injury is also pretty important. Hope is important, and that's a whole separate topic of research that I've done with people with spinal cord injuries. But again, do not extinguish hope by using phrases such as nothing more can be done for you, or this is a hopeless situation. Giving options and instilling realistic hope. And by that, I mean focusing on what the patient can do. So despite the injury, what can the patient do vocationally, physically, socially, going out. And so providing that, and which is realistic, I will do everything possible to help you, give your best in rehab. We know you can do XYZ activities, again, based on their abilities, and not giving them false hope. And having them engage in sports and recreational therapies are also a very important and a good way of realizing their abilities in that way. And that's a very indirect way of just showing them that there is a lot left despite the injury as well. Especially if it's people with paraplegia. Of course, people with tetraplegia have more functional difficulties, but again, what can they do best using technology becomes important in that way. Of course, you will be asked questions like, is there any cure? And of course, it needs to be sensitively shared that as of now, there's no cure currently available. And I know that a lot of people, at least in India, go for stem cells or miracle cures, whatever they can to focus on improving. But that also needs to be sensitively dealt with in terms of what stem cell research is showing. I mean, I always say that the prognosis is, the process is kind of like peeling an onion. You provide an initial overview, the patient asks questions, you answer questions, and then you go into more and more detail depending upon the patient's tolerance level and request and their life situation, and always follow up on the discussion in that way. When is a good question. People say, on admission and in acute stage, there may be just a lot of chaos and confusion because of all the medical procedures that are going on. People may not be in the frame of mind to assimilate information of that nature. And they may just say it's a matter of time. I know I will walk. They may be feeling overwhelmed. And all of these, again, are very normal responses to the injury. So I wouldn't worry about that. I would say allow the patient and the family to settle into a routine post-surgery. The pain's gone, the surgery site is healing, they're participating in rehab. The key factors in figuring out when to communicate is, have they raised any questions about the prognosis? Are they beginning to ask team members, the doctors, about their ability to walk or not? And are there major differences between the team and the patient's goals? So the team may want them to be functionally able to do transfers, bladder and bowel skill training, using splints to eat or whatever. But if the patient is not seeing them as goals because they think they'll improve, then again, that's the time when we intervene with the prognosis. Again, should be discussed between the patient and family, and ideally in a team conference where the discussion isn't just on the breaking news, but what are their current rehab goals. And again, short-term goals help with building up. Wheelchair prescriptions, are there any need for home modifications, any need for assistive technology? The importance of bowel and bladder management, because again, initially, I have learned that people may raise questions. The bowel and bladder loss is something which is also overwhelming. So again, that they can be self-reliant if they have the abilities to do self-CIC, but what would the bowel bladder management protocol be, and what their vocational and recreational options are. So that becomes important. Do not surprise or shock the patient or bringing these up when they are ready or are unaware of the prognosis or when you don't have time. A lot of times we may keep saying that a patient is in denial. I do feel denial is helpful initially. They engage in reality negotiation. It gives them time to process the shock and be able to cope with it when it comes. But like I said, people will keep probably till the end of their rehab stay, keep saying, I'm going to walk eventually, but they will continue to do everything that is needed to do in rehab. Is something that again is the way they are processing the news and how they're responding to that. But if they're acting on their erroneous beliefs that I don't want to work on these transfers because I'm going to just be able to walk, that becomes a point when we strongly intervene. And when there are overprotective family members who don't want to disclose that information, we often counsel them with the help of the psychologist to be able to tell them why it's important to let the patient know about the prognosis so that they can focus on their biopsychosocial integration in that way. I'm going to quickly wrap up about ending with a word about hope. At no point should any staff member take away the patient's hope. For them, it's important that they are focusing on reestablishing their identity and meaning and purpose and a vocation, and whatever is important to them, we need to consider that. So if there are support systems like role of hope, spirituality, and religion, we need to also enlist that as well. Please understand that we cannot force acceptance of the injury. Patients will assimilate this information into their psyche at their own pace and time. The only thing we can keep doing is just helping them build on their short-term goals towards the long-term goals in rehab. Some part of the present situation will get better when you reassure them. I have often people after 3 years of injury, when they, let's say, visit the hospital for the first time and were rehabbed elsewhere, when they get to know that sexual functioning can be restored using medications or devices, you should see how important that becomes for them, because they thought they'd lost all hope. So hope does not mean cure, but it means, can you be as self-reliant as possible? Can you aim for a better quality of life? And so again, focusing on functional capabilities such as driving, working, parenting, sexual functioning, involvement in recreational activities can happen, because they all assume that everything's doomed and they will not be able to do anything at all. So when you show them options and when you give them hope that they can resume these, it becomes important in that way. Information again should be realistic, based on the current medical knowledge, their abilities. But again, the focus is always on the self and on problem solving. If these patients are coming to you in the hospital, please empower them to be self-reliant from the time you meet them, because the shift begins in their stay at the hospital. And that's the biggest point that I would like you to take away from. And this, I strongly believe that the patients may not remember everything you said, but they will definitely remember how you made them feel. So, which is why I'm very passionate about this topic, about how we break the news and how we stay with them and support them as they process the news and focus on rebuilding their lives after a devastating injury like a spinal cord injury. Thank you so much. And if there are any questions, I'd be happy to answer them. My email is in the slides, and if there's anything that I could assist with, I would be happy to do that. And thank you for your patience, and wishing you a wonderful rest of the workshop. Thank you.